This week on the BackTable podcast.
If you provide a good service, you're available, affable, but also your ability is good too, you're talented, word travels fast, and that's what helps. You make the right connections, and a key thing is just be nice to everybody, because you don't know who that person is going to be that gets you to the next level.
Sure.
You know, you don't want to ever break it, burn any bridges, and then later find out, that person was the person in charge of this, thing that might get me ahead here. Just be nice to everybody, even when things get tough or other doctors are yelling at you, or not that they do, but just if you ever get into that position where you want to kind of fight back, just hold it back, take a step back, just be nice, and that's how it goes. That's how you get ahead.
I'm Dr. Baheti. I'm your host. I'm coming to you from Tacoma, Washington, where we actually have nice weather, similar to the guys that we're interviewing today who always have nice weather. Today, I'm happy to introduce two guests, Dr. Kartik Kansagra and Dr. Harout Dermendjian. They're independent interventional radiologists in California. Their corporation is called EVSLA. We'll talk kind of about what that stands for and what that means. They're both about 4 years out from training, and they're here to talk to you about developing and growing an independent IR practice. So Kartik and Harout, thank you so much for coming on the show today.
Of course, thanks for having us.
Yeah, thank you. Excited.
All right, so Joji has basically been begging to have you guys on the show for a long time now. So I'm glad that we were finally able to make it happen. I think you got lots of really important stuff to tell our audience. But let's kind of start with that. So you were both pretty active in SIR and things like that, as you were training. So tell me a little bit about where you trained and how that shaped your decision to go independent. Kartik, we'll start with you.
Yeah, I mean, you kind of name dropped the guy, Joji. So we trained at Kaiser Sunset with him. I got interested into interventional because I did a 4th-year med student away rotation with him. I think I told Don when I did an earlier episode, I actually planned it in the summer to do an away rotation in LA, because at that time, who's my girlfriend in long distance, I was like, I'll just come to LA for the summer. It'll be an easy rotation maybe, and I'll just hang out, in the evenings and afternoons. And it was definitely not that. It was a very long and intense rotation, but I loved every minute. And that's when I realized, hey, this is what I wanted to do. I was going to go into urology, and then I switched over, and then fortunate enough to match at Kaiser, stayed there for a few years as attending. And then ultimately Harout reached out and then joined him for our prior practice gig. But, training with V, you definitely, it's the most, I don't know, he's so infectious in terms of his passion for interventional. You just man, this is it. This is my calling. And, we knew that I love what I do. And so I was like, I want to do this day in and day out.
So that's interesting. So Harout, you had been out for a little bit kind of on your own. Did you also train with Dr. V?
I did. So I actually met Dr. V first year of med school. Actually, the second week of med school. Going into med school, I had no idea what interventional radiology was. But Dr. V came to my med school, which was USC, and gave us a lunch talk. And he was so passionate about the field that I knew that this is what I wanted to go in. So I've known him since that time. And I matched at Kaiser. Kartik was 1 year ahead of me there, so that's how we met. He was 1 year senior to me, and so we did training throughout together. And that's my story. That's how we met. That's how I met Dr. V. I've known him for 8 to 10 years now.
Wow. Yeah. Just one person and the inspiration that they provide, and kind of all the little seedlets that they create out in the world. Very few like him in the field. So tell me a little bit about what happened after you graduate. Harout, let's start with you.
So once I graduated, my first job was at all of UCLA, which is a county hospital. I knew I wanted to stay in LA. My wife and I are from LA, so we knew we weren't going to move out. So that was one thing. But another thing about that was I always had, just based on the way Dr. V trained us, is I always wanted to do more IR. And so this county job was a 4-day-a-week job. And on my 5th day, I was able, and then they did allow me to, do my own thing. So I started to kind of explore the private practice side of interventional in my first year out. And within 11 months, this opportunity popped up to completely go on my own and take over a hospital contract for interventional services only. And so that's what led me to where we are now. It was a little bit of me wanting to go out on my own, and a little bit of good timing and talking to the right people at the right time.
Yeah, I'd love to know more details kind of about how you either fell upon or were offered the PSA for a hospital to provide IR services for them. I'm sure there's an interesting story there.
Everything starts with just talking to the right people, being nice to everybody, and also doing good work and getting your name out a little bit. So all of that combining together is what leads to these opportunities, right? For me, in that first year, as I was doing starting my private practice in that 1 day a week, my name was slowly getting out as I was going and meeting doctors, but also being born and raised in LA, I knew I wanted to work in the area, and one of the main hospitals that I would drive by every day, I wanted hospital privileges. So at that 9-month mark, I reached out and I started asking med staff, hey, can I get on staff for privileging? And, in case I have any cases, I can bring them there. And so I started that conversation. And as we were having that conversation, the group that was there, they sort of were falling apart. And there was going to be a vacancy very, very shortly. And I was just talking to the right people at the right time. And that's how we started to negotiate about an offer and taking over. And I couldn't pass it up. I called Dr. V, I called some other mentors, and I was like, hey, should I leave my stable county job with benefits and everything and go on my own? Or do I just stay here and do what I'm doing? But again, the way I was trained, I was almost, I don't know how to say it, but I really wanted to go on my own and do more IR. I was getting a little bit...
Maybe one might call you fiercely independent. Okay, yes.
Yeah. It was a once-in-a-lifetime opportunity to take over or something like this and do something like this, I could have stayed at a comfortable job with good benefits, safe, but I decided not to. And it all worked out.
How long were you on your own before you brought Kartik on?
So I took over, I was about 11 months out of fellowship when I took over this contract. And I did it so I started that in July, and Kartik joined me in June. So the first 11 months, I was just trying to grow it as much as I could. And it grew rapidly. Just doing what we were trained to do, doing a good job, being nice, available, things grow rapidly. And so by that 11, 12-month mark, I was at a point where I just could not do it alone anymore. And luckily, I've known Kartik for a very, very long time. We were trained together. We think alike. We practice alike. And he was the perfect fit to come and join me.
So I mentioned it grew rapidly. I'm sure, like you said, in large part based on your availability, affability. Yeah, so really, I understand kind of like the basics of what it was like to grow this practice. But walk me through kind of like your day-to-day when you started in July of what you had to do to make yourself known and available and kind of build the case volume that you wanted.
Essentially, when I first started, it was kind of slower because I was taking over a sort of a more traditional IR practice.
Like what kind of cases did the other practice used to do before y'all started?
They would do a good amount of different things, but there was no rounding on patients or writing notes. There was no clinical aspect to it. But they were doing interesting cases. They were doing, all the lines and ports and things like that. They were doing some angiograms, embolizations. I think they were doing some onc work as well. So it was a good practice, but the clinical aspect was missing. That connection between patients, referring docs, and all that was missing. So when I first started, it was a little quiet, I didn't have to do 100 cases a day. So I was able to take my time, go around on all my patients, see all my patients, talk to the nurses, talk to the staff, talk to the referring doctors. And that's how I very quickly got my name out. And even right away, the hospital was noticing a difference between, let me think about this.
Yeah, sure.
The hospital quickly started to notice how the nurses, the referring doctors were responding to that kind of interventional practice. They liked it a lot more because they can actually communicate with someone, have a conversation. And they were more likely to refer patients now. And so that quickly went up to administration. And administration reached out to me, hey, we're hearing all these great things. Thank you for doing what you're doing. Keep it up.
Yeah, that makes sense. All of this like trajectory is kind of like the Horatio Alger dream of like IR, right? Like start from nothing and then you grow to this amazing thing. A lot of private practices the administrators don't understand IR, right? Like nobody in hospital administration understands it. They just understand like length of stay. They understand providing ancillary services to your surgeons or your medicine doctors. But it seems like one of the main differences in your situation was that you were able to develop this relationship with hospital administration where they gave you the leeway to grow the kind of practice you want. Do you think that's accurate?
So I have to give some of the credit to the prior group because about 10 years, I think it was 10 or 15 years prior to me joining, it was all one big traditional radiology group. And so at that time, that radiology group fell apart. And the new group was, they separated IR and DR. So about 10 years ago, IR and DR separated. And so when I took over, I only took over interventional services, which was really beneficial because in between cases, I don't have to read studies. I have no other responsibilities other than to my patients and to the procedures, right? So that's how I was able to have more time to go around and talk to people. I think that's a great benefit that not everybody has the opportunity to take advantage of. But I think that's the future. That's how you're going to grow an IR practice. You can't be confined to your desk in between procedures to read studies if you want to grow an independent IR practice.
Well, I guess now we can kind of get to the point where you brought on Kartik and, you're like, hey, buddy, I got all this volume. I'm doing awesome things. What was that conversation like between you two?
Yeah, so in between doing all my hospital work, I still had that other more outpatient practice going too with a clinic where I was seeing a lot of, venous disease. I was also seeing some arterial disease. So I was trying to grow a vascular outpatient practice. So everything was growing so much so that I wasn't able to adequately cover everything. And so I knew if it keeps growing this way, I need to bring on a partner. And we had been talking this whole time too. I always call him for advice or questions about cases, and we talk things through. And it just became natural that he was going to be part of the group soon. As soon as I got it to a point where I can bring him on, I knew that was the next step. Just because we were talking throughout the Kartik, you can say like, I would call you at least once a week about an interesting case and get your thoughts on it.
Yeah.
Yeah, and Kartik, you must have had a big mental decision going in your head to leave this amazing the Visla practice to kind of go off and join the small community practice. Walk me through kind of your mindset there and what you were thinking and kind of what made you finally make that leap.
Yeah, it definitely kind of like Rue was a very hard decision to make. Like you said, the practice at Sunset is amazing. We're doing high volume vascular work, like everything you can think of, aortic, like advanced aortic work, and clinic rounding, kind of everything that everyone wants their practice to be, that Dr. B and his team had built. And again, similar stability you get with the job at Kaiser, pension, benefits and whatnot. And I also actually just was about to, or I think I had a baby, right? Because we had a talk. He and I talked at the coffee shop across from the hospital my baby was like born in. And that's when he and I had this conversation. And I just had a baby too. And I was like, okay. But the biggest thing, for me, kind of like Harout, is the way we were trained. We were almost trained for this situation or opportunity, which is, okay, let's put you somewhere where there's nothing or, there isn't, big, robust practice, and let's grow it into something. That's how we were trained from day one in our residency to help build or create, a practice that's at Sunset at Kaiser. And so, for me, it was kind of similar. I was like, wow, this opportunity is what, I was trained for. It's like, you go through, we always used to joke, Harout and I, it's like you go through the Navy SEALs and then you're like, okay, now I'm just at a desk job. Not that there was a desk job, but you know what I mean? You're like, we trained to go into this situation where you want to build a practice, you want to create something of your own. And this opportunity similarly just kind of came upon me because I knew Harout and everything he was going through. And I definitely thought about it for a long time because I also really liked my job at Kaiser. I like the people, and I know we had plans there about different growth stuff, especially in the residency side. But ultimately, I decided, I also kind of wanted to help build something of my own and go out and see what we can make. Part of also as kind of like a testament to Dr. V's teaching and his, the way he trained us and everyone there. Like, I think you trained us the right way and we want to prove it to you. And so, ultimately I decided to join him. And that was in June, like you said, of last year. So now, yeah, we're past a little past a year.
Okay, yeah. Well, let's talk about the year that you've been together and what you think the biggest challenges you guys have faced from a practice building side. Kartik, let's start with you.
Yeah, so what's interesting, so kind of, I guess, to talk about our practice, we have, a mixed inpatient and outpatient practice, meaning we go to clinic, we get consults on the outpatient side for major service lines like vascular, pain, interventional oncology, whatnot. And then we have what we call our inpatient side, which is, the coverage you provide to a hospital. When I started, we had our clinic spaces and we were covering our main hospital, which is about 550 bed hospital. And that's the one we were really busy in. And at the same time, because of, what Harout's work and what he had done there, we're, like he said, spread to a nearby hospital. And then we'd gotten an opportunity to help cover their hospital as well. And so at that time, we took on a second hospital and our inpatient work also started to get, busier. And I think, so during that year, we helped grow that second inpatient side as well, all the while slowly growing our outpatient every day. So I think the biggest challenge, and her and I always talk about it, is, balancing the two sides. On the inpatient side, what you like is it's a steady flow of patients, and obviously we're two young guys. Like I said, I just had a baby. We have, young families and it's a steady paycheck. So that's nice. But all the time you spend on the inpatient takes time away, from outpatient. So it's trying to find this balance because you want to keep growing the inpatient. You get your name out, you get reps, you get experience. But at the same time, it does take time away from the outpatient. So I feel like one of the biggest, hurdles we're still figuring out is trying to find that key balance where allocating time, resourcing on the inpatient side, because we're still growing the inpatient side. Now we're at 3 hospitals and, but at the same time, you really want the outpatient. That's like our main goal. And it's growing, but it's kind of like 2 different slopes, right? The inpatient side, we've noticed, starts to become exponential growth. And then the outpatient is more of like a slow, steady, linear growth. And the slope of that line starts to become a little more horizontal as the inpatient exponential growth starts to go up because you have to naturally allocate more time to the hospital. Like our volume is just, a lot more. And so you spend less time on the outpatient side. And that's where you find like an inflection point where you're like, okay, now we're at the point, kind of I think what Harout felt when he brought me on is like, okay, we need to bring someone else on to continue to get that linear outpatient growth back up.
This idea of like the different growth models for inpatient and outpatient, because that's the truth. It's just what ends up happening is your inpatient starts growing a lot more as people know you become available, right? Can you talk to me a little bit, Harout, about how you structured the PSA with the hospital in terms of who does billing and how you get paid?
Yeah, so when we were having these negotiations 2 years ago now, they were presenting me with a couple options. One of them was to become an employee of the hospital and work that way. The other was just as a contracted group that covers the services. I always wanted to be independent, right? You don't want to ever be employed by a hospital because that would be the same situation that I was in before. It doesn't give you the freedom that you want to be an entrepreneur, essentially. And I wanted to model it like the other doctors were, the other clinicians, like the interventional cardiologists, the vascular surgeons, the urologists. I wanted that sort of a model rather than a traditional radiology model. So I had to go find a billing company to make my own corporation. I had to do all these things that we don't really know how to do, but had to figure it out on the fly and get it done.
Did you have to set up a EMR and like a systems for or I guess a practice management system for all your outpatient side, or were you able to use what the hospital already had for their other specialists?
The hospital has Cerner, so we don't have to worry about that. We rent out a clinic that's associated with the hospital, and that clinic uses the same EMR. So that's integrated and really nice for, like biopsy consoles, outpatient biopsy consoles, or oncology work, because it just ties in nicely to the hospital. But the other outpatient practices have a separate EMR.
And then do you have to pay for your own staff on the outpatient side, or when you rent clinic space, is all of that provided?
There's different models. There's models where you can set it up as an RVU based. So the clinic, if it's a hospital associated clinic, can provide you with the staff and you get paid an RVU based. Another clinic you can rent out, and it's different price based on if you're bringing your own staff, how much space you're renting out, if they're providing staff. So all of that is negotiable, and you can set, especially in the beginning, you want as little overhead. So you want to hire as many staff as you want, which is what I did. So I kept my overhead low by not having my own staff and, renting it. And then as you grow, you can hire your own people. But yeah, there's different options. Everything is negotiable. Everything you can, discuss how you want.
And the last group, the group that you took it over from, didn't have a clinic and all this.
They had a little clinic where it was like a pre-op clinic,
Okay.
right?
Yeah.
Associated with that hospital, associated one that I was talking to, they were going to that about a half day a week. It was like a pre-op clinic for like procedures. We have multiple clinic locations now, and that's just one of them. And so we're able to do a lot more with those clinics, a more traditional clinic where we see follow-ups too, and we see consults, and we do vein procedures, like varicose vein procedures. So it's a pretty robust clinic.
Yeah, no, for sure. Just like scaling to that kind of level of clinic, I think that's kind of a point of contention sometimes with hospitals is they're like, well, your clinic doesn't make any money. Why should we pay for this? You should really just be doing inpatient stuff. Did you have to have that conversation with your admin, or were they fully supportive of you growing this outpatient side too?
Yeah, it's great because they look at us as another member of the cath lab. So just like an interventional cardiologist has their own clinic, we have ours. So they don't look at us as a radiologist, they look at us as an interventionalist. We actually just had a community forum where they brought their interventional providers to give a talk, interventional doctors. So there was interventional radiology, there was interventional cardiology, interventional pulm, interventional GI. So they look at us as clinicians now rather than radiologists. And I was one of the speakers for the interventional radiology portion of it.
Cool, yeah. I feel like you guys have gained parity with vascular surgery and IC in that situation. Are both of those groups contractors for your hospitals as well, or are they employed physicians?
So there's multiple cardiology groups, and they all are part of a panel and call panel, but they all practice in the cath lab, whoever can get time. And one of those groups is hospital employed. The rest are independent.
Oh, that's interesting. They still have, California is so different, man. Like, I feel like California is the wild, wild west, you know? Like, literally.
It is with the hospital and insurance. Those two seem like just completely...
Oh, insurances are on another level.
That's like a whole different episode, I feel like.
You have, like, from what I know from California is that, like, California Medicaid actually pays really well compared to, like, other states' Medicaid. Is there more to that than what I know?
I mean, I think so. I think our payer mix that we see is not very high Medicaid, but I have heard that because I know within one of our hospital systems, there is a hospital where they see a high Medicaid amount. And now with, the big bill and kind of some plan changes for Medicaid reimbursement, there are concerns amongst that hospital about what will happen. And so I have heard that, but her and I don't have too many Medicaid, payers in terms of our patient mix. So I don't think we can comment too much on that part.
In California, for the Medi-Cal and Medicaid, it's just so hard to keep track of everything because there's so many different HMOs, IPAs. I get, reimbursement in every patient, every HMO, even within the same HMO with a different group, it all pays differently. So I can't figure out, like, sometimes they pay really well and sometimes they pay average or just below average. It's just so hard to keep track of which ones pay well, which ones don't. So it's a mix.
Yeah.
Yeah. So I don't understand it yet.
If it makes you feel better, I think most independent IRs deal with that and I understand insurance, obviously, but yeah, just understanding what a specific patient is what the charge is going to be or what I'm going to capture from doing a procedure, it's like kind of a black box. Once I think I got it figured out and then I see like what I actually got reimbursed, I'm like, wait, what? It doesn't make sense. It's either way higher or way lower than what I calculated. I feel like they just make these numbers up.
Yeah. It's so, and the same, like you said, the same patient or two different patients with the same insurance, some for the same procedure pays differently. We can't understand it yet. We've been trying.
Well, I feel you there. Yeah. Okay. So we talked a little bit about the billing challenges. Any other challenges you think are worth talking about kind of as you started this practice and have built it?
I guess since we're on the topic of insurance, we can talk about insurance contracts. I know there have been some episodes actually that have talked about it. I know Dr. Sudi's episode was her and I had listened to, we talked about it. And, some of the struggles he faced trying to get an insurance contract just to get them to understand who we are and how we practice and what we do has definitely been, I think, one of the biggest challenges for us. This takes years sometimes to get one contract. And whenever we go on calls with them, we try to explain to them, no, we go to clinic, we have to see patients, we have to follow up. They're always like, but you're a radiologist. That's like, they don't understand that, they think, no, it should just be, if somebody orders, like imaging study or quote unquote procedure, and, you guys do it, and then, somebody else takes over here. So that, I think, has been a huge challenge for us. I know Harout's been working with like one insurance for like 2 years. We just finally got our first contract maybe like 6 months ago, and it took them 6 months to get our like portal running. And so it's like, it's a steep wall to climb, but you got to do it, because for us, the biggest thing about it, really more than even being, in network or having that contract, is to be able to follow the patient after. Because, the biggest shock to me was, oh, you can't see the patient in clinic, or you can, I guess, you just can't bill for it because there's no pre-op for the office visit. And, even things like drains and stuff, we want to follow our own drains, because, we see far too often when we can't, people will get drains removed prematurely, or, then they just bounce back. And we've made these points to the insurance companies, like, we're actually trying to save you money. And we show them, like, look, we had X number of patients who bounced back, with your insurance, that we could have easily prevented by one post-operative, visit with us. And it's just, I don't know, for some reason, it's like talking to deaf ears. We're still struggling with it. So if anyone has any magic trick with that, we're all ears.
And this is more for the HMOs rather. The PPOs we got right away. It's the HMOs that don't want to give out contracts very easily, right? They want to be capitated with certain groups. And another hurdle has been trying to explain to them that we provide vascular services also, right? But they want all their vascular cases to go to vascular surgery. So that's where HMO, that's another hurdle that we've been trying to get over.
That's like so wild, right? Because if you can get the patient in faster than vascular surgery with the same outcome, you save that HMO a ton of money from like wound care, from all of the stuff that follows from, like foot infections, everything like that. They don't get it. What's the reasoning there? That
they want to be able to control their, I think they want to be able to control how much they're able to pay, or where they pay. They have more control when they're only capitated with one or two groups, versus having a bunch of different doctors, a bunch of different specialties providing that one service. It's about being able to control the market.
Yeah. Well, yeah. Like I said, California is wild. I'm glad you guys practice there and not me. How about kind of like gaining acceptance amongst the other service lines that exist within the hospital, like the surgeons, cardiology, urology, like all the people who like sometimes shit on IR, right, to do dumb stuff. My guess is like the old group probably, was more of a traditional IR group that said yes to a lot of stuff. And how have you been able, or have you pushed back at all, established boundaries, especially as you kind of bring on these additional hospital contracts, just to save yourself and save your time in practice?
You have to balance saying yes and doing dumb things, I guess, especially when you're trying to grow. And what helps a lot with that is seeing the patient and writing a consult note. That's the key, right? So you have to be able to explain your thought process. You want to say yes to everything you can and you should do. And picking up a phone, calling the surgeon and having that discussion, either in person or on the phone, is very helpful, right? A consult note explaining things to the patient and having the patient say, hey, no, I don't think I need this. This goes a long way as well. Then you say, look, I talked to the patient doesn't think this is the right thing. They don't want this. So, you have that discussion with the patient rather than having the other doctors order it. Because when I first started, they were putting CT biopsy order or CT drain orders in. And I had them change that to put a consult in for me. And I'll go and make that decision. And, I would say yes to a lot of things, but I would explain why. And when I did say no, I would also explain why. And the referring doctors appreciate that, actually.
Yeah, for sure. And we do like a terrible job as the IR community documenting our decisions, right? Just because most folks don't work in the EMR system. They work on the PAC system. Yeah, having solid reasons why you're saying no to a procedure or saying this can wait till the morning, I'm sure that goes a really long way. How did you envision this practice growing when you first started it?
Well, another important thing for me was when I started this out is, and then Dr. Vatican Cherry would hammer this in too, is you always have to have a 1-year plan, a 5-year plan, and a 10-year plan, right? So I set that up in the beginning. Before I started, I had my 1, 5, and 10-year plans. And I was able to achieve my 1-year plan. But in order to get to the 5-year mark is when I had to bring on Kartik. So I could have stayed at the status quo after that 1 year, but I knew I wouldn't be able to get to my 5-year goal without another partner or two. So that's how you're able to grow. You always have to be thinking about growing, or else you either stagnate or fall behind.
One, I would say I think anyone can do this, and the quality of the training matters a lot too. And I think that was a huge part of our success, is if you're trained the right way, when you go out and you're put up to the world, you're trained to succeed. And I think a key component of that, is being able to go to clinic as a resident. Because we used to go to clinic every week. We had our own clinic as residents, and we followed our patients. And, all of us that do outpatient work know the discussion with the patient in a clinic, very different than discussion with the patient in a hospital bed. Usually in the hospital, you're telling someone, hey, I need to do something because you absolutely need it. But in the clinic, you're trying to talk to them like, hey, you should let me do this PAE over, the aquablation, or it's a very different discussion you're having, and you need to learn how to have that discussion. You can learn definitely, we're learning new procedures. We're learning how to have those talks, now, but having been able to do that in clinic and training as residents with the oversight of attending and, having done that hundreds of times makes it second nature when you go out on your own. And so I think if you really want to build an outpatient, if you're a resident listening, talk to your program director, like, hey, I want to have a clinic, or I want to go to a clinic where I can learn to see these patients, talk to them and follow them, and, follow your patients throughout your residency, and you'll see how your procedures work, how they don't work, what happens after, how you can manage them and their disease. I think for us, that was a huge part of, our outpatient success is, we'll take, these outpatients and we'll manage their disease, and we can talk to them about everything. We just take care of their BPH really, or, we manage their PAD. I mean, the revasc is one part of it, but the wound care PAD as a whole is really what we're mostly doing.
Yeah. And then kind of getting back to kind of how you originally started the practice, Harout, how do you find the right person within the giant behemoth that is hospital administration to contact and to engage with about taking over a PSA for a hospital?
I initially just reached out to med staff and just started talking to people. And then you kind of start to meet different people at administration, and you'll figure out which ones at one hospital it might be this person who's more the person to go to and kind of get things done. At another hospital, it might be someone else. Some personalities are more open than others. So you just have to kind of figure it out, talk to everybody, and just feel out who your go-to person is going to be there. I don't know if that answers it correctly, but it's not like one person at every hospital.
Yeah, I guess it's super variable. You sounds like you were kind of just like right place, right time, and providing good care, and that's kind of how it worked out in your favor. But then the fact that you've been able to grow that now to like three total hospitals, there's really a testament to your guys' skill and dedication.
If you provide a good service, you're available, affable, but also your ability is good too, you're talented. Word travels fast, and that's what helps. You make the right connections. And a key thing is just be nice to everybody, because you don't know who that person is going to be that gets you to the next level.
Sure.
You don't want to ever break it, burn any bridges, and then later find out, that person was the person in charge of this, thing that might get me ahead here. Just be nice to everybody, even when things get tough or other doctors are yelling at you, or not that they do, but just if you ever get into that position where you want to kind of fight back, just hold it back, take a step back, just be nice, and that's how it goes. That's how you get ahead.
As we wrap up, anything else you guys want to tell our audience? Closing words? Harout, let's start with you.
Training is the time to learn everything. It's not a time where you should be, taking it easy. You need to be working as hard as you can in training so that when you get out, everything is easier. Because right now, when I'm growing this, there's a lot of other stuff that I have to deal with, like paperwork, administrative stuff. I can't be learning how to do procedures or fumbling with, clinical things, because then it sets you back on your administrative side if you want to grow a practice. So training is the time to really hone your skills. If you have the opportunity to stay late and do a couple extra cases, even if they're simple cases, do it. Come in early, round on all your patients. Make sure you know your list better than your attendings or your co-residents. These are the things that are going to get you ahead later.
Yeah, having that solid clinical foundation, 100%. Kartik, any last words?
I encourage anyone who's even thinking about doing this to do it. I mean, we love our job. Most people who do interventional love interventional. And I know most people, unfortunately, get kind of held back by a ball and chain with association with radiology. Based on at least my small end of people I've talked to who have thought about it or, who are in prior practice is kind of just try to break free and do what you want to do. It's definitely hard. It's a lot of work. Her and I are probably always working. Even when we're on vacation, we're answering phone calls, or you're always working. But at the end of the day, we get to build something that's our own and we get to do it the way we want to do it. And I think you can't put a price on that.
Awesome. You guys are an inspiration. I'm sure a lot of young interventional radiologists, residents, fellows, early career folks have learned a lot from this episode and would literally dream of the practice that you've grown and built. So thank you so much for coming on the show today.
Thank you.
Thank you.
Thank you guys so much for tuning in. If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Baheti,
Michael Barraza, Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.